session, Dr. Kajal Prasad Ghosh. Kindly take your seat on the stage, sir. Most welcome. Co-chairman, Dr. Biti Chaudhary. Welcome, ma'am. Dr. Subhash Dadia, sir. Is he here? Dr. Subhash Dadia, sir? No. Co-convener, Dr. Manas Kumar Ghosh. Sir, are you here? No. Kindly. And first speaker, kindly get ready, Dr. Sanskriti, with the topic of clinical profile of retinopathy of prematurity screening and management. Each presenter has 4 minutes. Kindly stick to the time. Meanwhile, Dr. Niranjan Karthik, if you could take the other podium. Just 4 minutes. So kindly take the other podium and let's not waste time. Requesting the other speaker to be ready. So Dr. Sanskriti, please load the slides. Please adjust the slide. Adjust the slide to the size of the display, please. So you have 4 minutes. Time starts now.
Okay. Good evening, everyone. I'm Dr. Sanskriti presenting on topic clinical trends in ROP and its management. ROP is one of the most common preventable ocular disease in premature, if not treated, leading to blindness. With increased number of SNCU, there is an increased number of preterm neonates, resulting in increased incidence of ROP. Therefore, appropriate screening and timely treatment are important. The aim of our study was to determine the incidence, risk factor, and treatment outcome of ROP in an institute, which is SMC REVA. The study was done around September 2022 to April 2023, and the sample size was around 623, and the study design was a cohort study. The study participants were around all infants with birth weight less than 2 kg and the gestational age around 36 weeks. Baby with higher birth rate or gestational age if advised by their neonatologist. ICROP3 was used for classification and standard guidelines were used for its management. Incidence, risk factor, and treatment response were noted. In our study, in 623 infants, ROP was diagnosed in only 51 infants, in which type 1 was around 34. In 34 babies, in which in 29 we gave anti-VEGF, 80 have regress ROP, and 11 needed further laser. In 5 babies, we have given laser, which had regress ROP. The overall incidence of our ROP was around 8%, but in preterm, the incidence of ROP was more, around 13%. The mean gestational age for ROPs, we were 32 weeks, and mean birth weight was around 1.4 kg. In my study, we found out the AROP frequency was more, which was around 25 babies diagnosed with AROP, followed by stage 1, followed by stage 2 and stage 3, and followed by stage 4. There was no baby with stage 5 ROP. In AROP, zone 1 was more common than zone 2. RDS, exposure to oxygen, and multiple gestation, low birth weight were found to be a significant risk factor associated with ROP. When we compared our study with different studies published in India, the incidence was less compared to other studies, but the mean gestational birth weight was similar. Low birth weight and number of days of oxygen and RDS gestational was significant risk factor, which was similar to the study published by Kumar et al. In our study, zone 1 AROP was most common than zone 2, whereas in different study in India reported zone 2 be more common. Tekchandani et al. Reported 15.6% babies with stage 4 and 5 ROP, when our institute, the incidence of stage 4 ROP was much lesser, which was around 3.94%, and no baby was detected with stage 5 ROP, suggesting a better screening protocol in our institute. Conclusion, in my study, the incidence of ROP was 8% and preterm was 13. RDS, exposure to oxygen, multiple gestational, and low birth weight was significant risk factor. there was a high incidence of AROP, and anti-VEGF was most common treatment modality used.
Okay. Kindly.
On only one institute.
One institute.
Yes,
Okay.
ma'am, only one institute. We got referred in our locality region. Our institute is only tertiary healthcare center. So we get referral cases also from district hospital and other hospitals.
Okay. So, what was the outcome of the treatment?
Ma'am, in treatment outcome, all babies fortunately have regressed ROP and mature retina. In last, there was no baby with stage 5 of ROP. And after anti-VEGF, even we don't even have a complication like RD or something like that during our study period.
Okay. Thank you.
Thank you.
Okay, Dr. Niranjan Karthik on the topic Seeing the Unseen World, Role of Vision Therapy in Improving Quality of Vision and Life. 4 minutes.
Thank you, sir. Good afternoon to one and all. So today we're going to see an interesting topic of seeing the unseen world, the role of vision therapy in improving the quality of vision and that of life. So basics first, binocular single vision is the ability to use both eyes together, a single fuse perception even in the presence of disparity of the image seen by individual eyes. What is vergence? Simultaneous movement of both eyes in opposite direction, and accommodation is a process by which the eye changes its optical power. Now we know the three grades of BSV: fusion, simultaneous perception and stereopsis. So what is lazy eye? Basically reduction in vision in one eye caused by abnormal visual development in the early part of life. And what is vision therapy? Fully customized and personalized method to improve and strengthen the visual skills and retrain the visual system to harness the hidden potential for better quality of vision. So this is our foundation for the study. So our aim was to study the outcome of this vision therapy in improvement of the quality of BSV. That includes stereopsis and also accommodation and vergence. And also the added benefit was improvement in the best corrected visual acuity in patients with subnormal vision. So all patients with defective binocular single vision, amblyopia and vergence insufficiency were included, and those with strabismus due to neurological causes were excluded. So this procedure or the study had two main components. One is the assessment followed by vision therapy. So the assessment, though looks complex, it's quite simple. It entails detailed history taking and followed by proper refraction, first with autorefractometer and then with proper subjective refraction. And in many cases, as indicated, we had to go for cyclorefraction followed by post-mydriatic test, after which the refractive error was finalized and the spectacle correction was given. So what is vision assessment comprise of? So regular vision assessment is what we already spoke of, subjective and objective refraction, whereas orthoptic evaluation had these four components assessed in using different tests as shown in the red boxes. So for this scarcity of time, just we'll assess them under these four headings of sensory, motor, vergence, accommodation and stereopsis. And following this, the ideally indicated candidates were started on vision therapy for two major things. One is for strengthening the focusing ability and improving the maintenance of this focusing ability. They were done using different tests as shown here. The strengthening was done by pencil push-ups, CAT card, lifesaver card, etc. While maintaining of this was done by equipments using Brock string, vectogram, gyroscope, etc. So what were the results? A total of 33 patients were included in our study, and the age ranged from 5 years to 27 years of age. The mean age was 11.4 years. The worst corrected visual acuity was 636. It's important to note that 91.3% had an improvement in best corrected visual acuity, as we can see here, and it varied between the different eyes as shown here. And this was clinically significant as the p-value was quite less than 0.01. Secondly, the stereopsis, NPC, vergence and accommodation also improved, and they also had statistically significant correlation as done by T-pair tests. Okay, and moving on to discussion, 91.3% had shown improvement in BCVA, 34.77% showed improvement at least 2 lines, And other parameters like stereopsis, near point of convergence, vergence facility, and accommodation facility, all of them showed statistically significant improvement. And last but not the least, binocularity, remember, is a gift to mankind. And there are only few conditions of medicine where it requires the cooperation of a team, including ophthalmologists, parents, and the child. And this vision therapy has proved a great difference in our clinical practice in treating amblyopia and abnormal BSV. Thank you. Yes, ma'am.
So, for treatment, you have given spectacles
Yes, ma'am.
and
The different components of vision therapy for.
to improve their binocularity, is it?
Yes,
Binocular
madam.
vision.
Yes, ma'am.
Okay. And then you have assessed. So, what are the various categories of treatment did you give?
Ma'am, first is the corrective, refractive correction that we
Yeah,
have given using
yeah.
glasses after a cycloprasic refraction. Followed by that, there are two components. One is to strengthen the binocularity, for which we used cat card and pencil push-ups. And for maintaining this focusing ability, we use Brock string and vector charts, etc. So we use the different parameters, different equipments for improving on different parameters.
So, you have the data of how many patients required these, or you use them in all patients?
Ma'am, those because of the paucity of time, I couldn't explain them in detail, but each patient was tailor-made for their deficiencies. Let's say their NPC was affected, they had more to do with pencil push-ups and convergence exercises, whereas those with difficulty in fusion, etc., were using gyroscope, so it was tailor-made for each one of them, ma'am. Thank you, ma'am.
Is Dr. Smriti Lekha Sahu to assess the efficacy of atropine 0.01% to control the progression of myopia in pediatric eyes.
Should I start?
Start.
Good afternoon, everyone. So, I am presenting my research on the safety and efficacy of 0.01% atropine eye drop to control the progression of myopia in children between 5 to 15 years of age. As you all know, according to the global prevalence of myopia study, approximately 49.8% of the world population are going to become myopic by 2050. And as the level of myopia increases, it also leads to increased risk of retinal detachment, choroidal neovascularization, etc. So the aim of my study is to assess the safety and efficacy of 0.01% atropine eye drop. My primary objective is to assess the safety and tolerability, and my secondary objective is to assess the efficacy. It was a prospective case control study that was carried out in JPM Rotary Eye Hospital from May 2022 to April 2023. We included the children of age group 5 to 15 years with documented active myopia progression of at least minus 0.5 diopter, with refractive error of spherical equivalent of minimum minus 2 diopter, and with astigmatism of less than 1.5 diopter. Children with strabismus, amblyopia who are hypersensitive to atropine, they were excluded. 100 myopic children were recruited. Case group was taken as the right eye of the 100 myopic children, and control group was taken as the left eye was taken as the control group. We administered 0.01% atropine solution to the case group and 0.5% CMC solution to the control group. Children were followed up at 4 months, 8 months and 12 months to measure the spherical equivalent K1, K2, axial length, ACD, lens thickness and retinochoroidal scleral thickness. Outcomes were measured in terms of spherical equivalent and axial length at 12 months. As you can see from this result, in case of case group, the progression is minus 0.15, whereas in case of control group, it is minus 0.62, and the p-value is less than 0.001. That is, it is clinically significant. Also, in axial length, the progression is 0.15, whereas in case of control group, it is 0.59, and the p-value is less than 0.007, so it is clinically significant. This is the time series plot depicting the progression of spherical equivalent and axial length over 1 year period. As you can see, in case of control group, it is increased from minus 4.81 to minus 5.43, but in case of case group, it is mostly constant. Also in axial length, In case of control group, it is increased, and in case of case group, it is constant. We also evaluated RCS, but it was clinically insignificant. No adverse reaction were found during the study period. So coming to discussion, pediatric myopia contributes to 22.9% of the world population. Recently, different studies like ATOM-1, ATOM-2, LAM studies, they have already shown that 0.01% atropine has a better treatment to side effect ratio. But they did not consider about the confounding factors. So the effect of confounding factors can be eliminated if one eye of the individual receives the treatment and another eye of the same individual can act as the control. Considering this existing paucity in the literature, our study aimed to study the myopia progression and axial length elongation in Indian population with one eye as the treatment and the fellow eye as the control to evaluate the efficacy of drug. In our study, the mean progression in axial length in the case group was 0.15 plus minus 1.04, and that of control group was 0.59 plus minus 0.65, and that was very similar to LAMP and ATOM-2 studies. So I conclude that 0.01% atropine eye drop can be considered safe as well as effective to prevent the progression of myopia in age group of 5 to 15 years, as the results in our study show statistically significant difference. Thank you.
Uh, 0.01% atropine is now well known to control myopia.
Yes,
Whether you do it in as a contralateral eye study or you do it as an isolated study, there will be a proportion of eyes that will escape 0.01% atropine also, and there will be a proportion of eyes which will not progress, whether you use 0.01 atropine or you don't use. Okay, so there's some amount of doubt in the design of your study, but then the content is something that we have to ponder upon. Adding to that, you said there are a lot of confounding factors regarding the
like outdoor activities they are doing, their near work, their screen exposure.
Yes, so were these factors taken into account? Like,
Sir, that's why we took right eye as the case group and left eye as the control group, so that these kind of confounding factors can be eliminated.
okay.
So if you are succeeded in reducing the myopia in the right eye, the left eye, if you have kept in a control, then left eye will be in problem in future, isn't it?
Sir?
What I mean, because this is already an established fact that this atropine reduces the progress of myopia. And in your study, you have kept one eye for control and one eye gave carboxyminyl cellulose, and one eye you put that here. Okay, and the person. So 1 year after, 2 years after, when you see the patient, you will suffer from anisometropia. If this eye is controlled and this eye is not controlled, isn't it?
Sir, actually there were not much difference. In right eye, in case of case group, there are also spherical equivalent was also increasing, but in case of left eye, that was the control group, spherical equivalent was increasing rapidly as compared to the case group.
That's why so 2 years after, she will suffer from anisometropia, isn't it?
That is to say, a contralateral eye study is less ethical at this point when you have evidence that atropine 0.01% can reduce progression of myopia.
So other is
And,
progressing.
and given
So
that your
you'll-
study endpoints were safety and efficacy, safety is already well proven in the whole of the world population.
Sir, but still we are in the experiment phase, and we have not established the data completely, so.
Chalo, just for the information of the house, there are new concentrations of atropine also being tried.
0.05%, 1%, but sir, more side effect were there, and progression occurs after rebound effect occurs in 1% and 0.05%.
Okay. So Dr. Vaishnavi K. Adappa.
Okay, thank you, sir.
Okay. Beyond the birthmark, the silent threat of glaucoma and Stouch-Weber syndrome.
Good evening. My presentation is on the silent threat of glaucoma in Sturge-Weber syndrome. I'll be presenting a case report of Sturge-Weber syndrome with secondary open-angle glaucoma. So Sturge-Weber syndrome is also known as encephalofacial or encephalotrigeminal hemangiomatosis. It's a neurooculocutaneous syndrome with congenital hematomas involving the eye, skin and the brain, characterized by the presence of choroidal, episcleral or conjunctival hemangiomas, presence of port wine staining in the skin, and presence of leptomeningeal hemangiomas in the brain. The glaucoma in Sturge-Weber syndrome occurs due to either anterior chamber angle malformation or elevated episcleral venous pressure. So a 7-year-old girl with Sturge-Weber syndrome was referred by the pediatrician for detailed ophthalmological evaluation. She had port wine colored lesion in the right upper part of the face since birth, and there was history of one episode of seizures in the past. There was no family history of any neurocutaneous disease. This picture shows the presence of port wine colored stain or nevus flammeus in the right upper part of the face, which was present since birth. Non-contrast CT of the patient showed multiple dense areas of calcifications causing volume loss along the cortical and the subcortical regions of right temporoparietal occipital lobes, causing tram track sign. On examination, the visual acuity was 6/60 in the right eye and 6/12 in the left eye. Anterior segment evaluation showed bluish discoloration of the conjunctiva and episclera bilaterally, and intraocular pressure in the right eye was 29 millimeters of mercury, and in the left eye, IOP was 15 millimeters of mercury, which was measured with eye care. Gonioscopy showed open angles in both the eyes. Fundoscopy done showed a cup disc ratio of 0.8 in the right eye with bipolar neuroretinal rim thinning, and in the left eye, the cup disc ratio was 0.5 with intact neuroretinal rim. Background retina was normal in both eyes. So the patient was diagnosed as Sturge-Weber syndrome with right eye secondary open-angle glaucoma, and for management, the patient was started on dorzolamide eye drops for the right eye, and right eye trabeculectomy under guarded visual prognosis was advised. Discussion: around 30 to 70% of patients with Sturge-Weber syndrome present with glaucoma, out of which 60% of these patients present at birth who have congenital glaucoma, and the rest 40% manifest glaucoma later in life. The cause for congenital glaucoma in Sturge-Weber's is thought to be due to anterior angle chamber malformations, which can be due to widened uveal meshwork or anterior insertion of the root of iris or direct insertion of the ciliary muscle into the trabecular meshwork. And the late onset glaucoma in Sturge-Weber's is thought to be elevated episcleral venous pressure, and in some cases due to premature aging of the trabecular meshwork. Increased incidence of glaucoma is seen in cases of port wine staining involving the upper eyelid, and also port wine staining involving both the sides of the face. It has also been seen that the glaucoma incidence is more in patients who have both V1 and first and second dermatome of trigeminal nerve involved. So concluding, this case report highlights the importance of early detection of glaucoma and multidisciplinary approach in the management of patients with Sturge-Weber syndrome. It also signifies the need for addressing both the ophthalmological as well as the systemic aspects of this condition in order to provide the best possible outcome for the patient. Thank you.
So, what was the age of the patient?
7-year-old, ma'am.
7-year-old child. Okay. So, was it a bilateral or was it a unilateral
Ma'am, the port wine staining was bilateral, ma'am. But the intraocular features, there was only melanosis in the conjunctiva and the episclera bilaterally, but the IOP was higher only in the right eye, and even CNS findings were unilateral, ma'am, only right-sided.
Okay. So, what was the cause of this glaucoma, you said?
It was open-angle glaucoma, ma'am.
What type?
Secondary open-angle glaucoma, ma'am. It was not present at birth.
So, secondary to what?
Probably due to elevated episcleral venous pressure.
Right.
My question would be, how does it justify the title, The Silent Threat of Glaucoma, when you have such a big port wine stain on the face?
Suppose the patient was not evaluated for ophthalmologically, sir, and the patient was only given systemic treatment for Sturge-Weber's, the IOP would not have been controlled either through medical or surgical management, and it would have caused further loss of vision.
So now the issue is rather social, that if the child is being exposed to proper screening and proper referral, so that aspect is something that you need to touch upon.
Yes,
so how many points of contact the child has had previously with a pediatrician or a health worker?
with the pediatrician alone, the child had contact, sir, since birth. However, this was the first ophthalmological visit that the child had,
First
sir, at 7
ophthalmological
years
visit.
of
So
age.
yes, the whole of the immunization cycle has been completed, but the child has not been evaluated ophthalmologically. That is something we as an ophthalmological association have to ponder.
And
Right.
what about the fundus details? Did you mention?
Yes, ma'am. The fundus in the right eye, the cup disc ratio was 0.8, and there was bipolar neuroretinal rim thinning.
And the
ma'am.
other eye?
Other eye, it was just 0.5 CDR with no
We have
no
slides.
neuroretinal.
We have
Yeah,
slides on it.
Yes,
she
yes.
did have
She-
slides for that. Okay, nice. Thank you.
Thank you.
Dr. Vaishnavi, and now for Dr. Preeti, the causes of blindness and visual impairment among children.
Good evening, everyone. I am presenting the causes of blindness and visual impairment among children. Introduction is children are the future and hope of mankind. Statistics reveals that over 12 million people who live in the country are visually handicapped. Prevalence of blindness is high in states like Madhya Pradesh and Rajasthan and other states like UP, Andhra Pradesh and Maharashtra. The number of blind children in the world was 1.5 million in 1990, which reduced to 1.4 million in 2015. It is estimated that at least 2 lakh to 3 lakh children in India have severe visual impairment or blindness. Although this represents a small percentage of the estimated 5 million blind in India, it is significant in terms of blind years. This is retrospective cross-sectional study at Tertiary Care Center based on record-based data of last 5 years of children having blindness at Tertiary Care Center. Total number of cases is 2 to 7, and the inclusion criteria is age between the 1 to 15 years and the presence of visual disability certification. And the results are the maximum number of the cases is present between the 12 to 15 year age group, which is 123, and the minimum number of cases is present between the age group of 3 to 5 year, and which is 15. According to sex, maximum number of cases are males 151 and the females are 76. According to residents in rural area around 70% and in urban area around 30%. According to religion is Hindu is 83% and the Muslims around 16%. On the basis of cause, congenital causes are around 80% and the acquired causes are around 20%. In congenital causes, maximum number of cases are due to iridofundal coloboma, followed by pathological myopia and congenital glaucoma, hereditary optic atrophy, and corneal opacity. And the few cases are also due to the congenital toxoplasmosis, Lawrence-Small-Biddle syndrome, and hereditary vitreoretinopathy. In acquired causes, maximum number of cases are due to refractive error and the trauma, and others are also due to deficiency of vitamin A, chemical injury, retinopathy or prematurity. In avoidable causes, maximum number of the cases which we can avoid are included in trauma and retinopathy or prematurity and due to vitamin A deficiency. In discussion, in our study, maximum 16% were due to iridofundal coloboma, followed by 12% were due to thiazical and 8% by pathological myopia, 8% by chorioretinal degeneration and corneal opacity, whereas minimum by hereditary vitreoretinopathy, followed by Coats disease, Sturge-Weber syndrome, congenital toxoplasmosis. As per acquired causes of blindness, maximum were due to trauma, followed by refractive error, and the minimum cases are due to chemical injury and followed by the retinopathy of prematurity.
Please wind up.
Conclusion. Childhood blindness is predominantly found in 12 to 15 year age group associated with the malpreponderance. Congenital causes were abundant. Almost 20% cases were blind due to avoidable causes. The study emphasized the need for screening of blindness in early childhood. Our result highlight the importance of early diagnosis for prevention of childhood blindness. Thank you.
So the first point I'd like to make is that we have marks for slides, whereas this was a scrolling Word document. Is there a specific reason for that?
I think time is short, so.
I hope my co-judges take that into account. Secondly, you have mentioned various congenital and acquired causes. Whenever it is, you have such a long list, it is better to present them as in the form of a diagram or a bar graph or a percentage that is visually understandable. Okay. That would be one comment. And what was the setting in which this study was performed? I mean, the clinical setting. Is it an urban hospital, a rural hospital, a referral center?
At the Tertiary Care Center, SPMC Bikaner, PBM Eye Hospital.
Urban Eye Hospital.
G.
Right. Okay. Okay. Thank you, Dr. Preeti. The next speaker is Dr. Bhavna Parmar, Incidence, Risk Factors, and Clinical Course of Zone 1 ROP. Time starts.
My topic is to study the incidence, risk factors, and clinical course of Zone 1 retinopathy of prematurity. India is facing the third epidemic with the incidence of retinopathy of prematurity, which ranges from 38% to 47% in different regions of India because of improved neonatal intensive care units with a greater accessibility of NICU and improvement in the survival rate of premature infants. Zone 1 retinopathy of prematurity is characterized by rapid progression of the disease from stage 1 to stage 3 within a matter of days and has a tendency to progress to retinal detachment with extremely poor visual outcome if not treated timely. That out of 3 zones, the Zone 1 retinopathy of prematurity is the most aggressive one as it is the most important area in aspect of the vision and vascularization is so immature, the laser landmark will not appear that soon. It is a prospective case series, which is the study center is Department of Ophthalmology, Gandhi Medical College, Bhopal, and duration of my study was January 2021 to December 2022. It included all the preterm infants whose parents gave informed and written consent for the screening, and they diagnosed with Zone 1 retinopathy of prematurity, and subdivided in type 1 and type 2 on initial presentation. And ROP was classified according to the international classification of ROP 3. My result were total 526 neonates were screened, in which ROP is present in 131 children, in which Zone 1 ROP is in 50 neonates, which is in type 1 there is 32 and in type 2 that is 18, with an incidence of Zone 1 retinopathy of prematurity is 9.5%. In risk factor, in type 1 retinopathy of prematurity, the males were 20 and females were 12. And in type 2, both male and female has 9. That it is not significant. In gestational age, the extremely preterm infants will is less than 28 weeks. They are more in type 1 ROP. And as we goes to the normal 35 to 36 weeks, there is more type 2 retinopathy of prematurity is more, with a significant p-value of 0.034% and birth weight in less than 1 kg. The extremely low birth weight, they are more in type 1 ROP as compared to type 2. The mean birth weight, it's significantly, the mean birth weight, the mean duration of NICU hospitalization, oxygen supplementation and ventilatory history of the patient is significant in type 1 ROP in zone 1, and all the other risk factor like respiratory distress syndrome, surfactant, asphyxia, sepsis were not significant, statistically significant. The maternal risk factors like preeclampsia, eclampsia, twin pregnancy and born with in vitro fertilization was not statistically significant. In zone 1 retinopathy of prematurity, 97 eyes we have taken. At type 1 ROP, 8 presentation, 34 eyes are present with type 1. In type 2, there is 63 eyes. But on frequent follow-up, the more than half, like 30 eyes, were converted to type 1 and treatment is given to them. And in my discussion, there is also a study by Uchida, Senpi. They were find that zone 1 ROP, which is a treatment group ROP type 1, which is more common in extremely preterm infants and which have very low birth weight. The conclusion, the extreme preterm and extremely low birth weight is a significant risk factor for zone 1 retinopathy of prematurity, and nearly 50% of type 2 ROPs converted to type 1 on follow-up, so finally a distinct follow-up is necessary. These are my references. Thank you.
So, what are your, did you give therapy to these children also?
Yes, ma'am. In type 1 ROP, we have given anti-VEGF and followed by laser therapy. And in some patient in which laser landmarks are visible, we go with laser therapy if anti-VEGF is not available at that.
So, did you look into this factor also, that which are the comorbid conditions which are causing, which are making the children more at risk? You talked about preterm babies, very early preterm, but you have not talked about other comorbid features, maybe septicemia, maybe some other thing. But that you have not mentioned, and you have not given any slide also. You just written 2 lines on it.
Yes, ma'am. Actually, I have taken the sample size is very low in zone 1 only. I have taken, and in that sample size, the septicemia and this was not significantly statistically significant.
But that should be mentioned. Should be. I mean, I feel that it should be mentioned in that, because many things are not statistically significant, but they are significant as such, isn't it? So
the results can be presented, but they might not be emphasized during your presentation. That's what ma'am is implying. What I wanted to know is the novelty in your study. Like, okay, you found the incidence, but what about the risk factors? Like the risk factors of AP-ROP or AROP as we call it, or even type 1 or zone 1 ROP, they are quite evident as of now. And we have a lot of literature, not just what you presented. We have literature from all over the world, and especially India, which is saying that a lot of ROP is now getting detected earlier than usual, and therefore
especially
more
in India
yes, and more aggressive forms have been identified. There's a term which has come, which is hybrid ROP and things like that. So a lot of work is being done in ROP, and probably this study is lacking a bit of literature review in that regard also. So do you have a comment? Do you have a comment, sir? Okay. Thank you, Dr. Bhavna and Dr.
What you were saying.
Thank you, Dr. Bhavna and Dr. Naila Aftab with her presentation on systemic associations of congenital ectropy and UVA. May we have the slides?
It's not visible.
Slides, please.
Slides are not visible.
Okay. Slides are not loaded. Okay. Probably there's some technical glitch. Dr. Naila, you can sort it out. And meanwhile, we move to the next presenter.
रोहित छोड़ दे यार.
Dr. Ritu Singh, are you here? Yes. Okay, maybe Dr. Naila can sort it out, and till then we can listen to Dr. Ritu Singh on comprehensive study of prevalence, risk factors, and treatment outcomes of ROP in a tertiary hospital. A lot of ROP work going on.
A very warm good evening, respected delegates, and a small yet intellectual audience here. Indeed, it's kind of a continuation to Dr. Parmar. I'm going to speak on retinopathy of prematurity in a tertiary healthcare center in UP. I do not have any conflicts of interest or any financial relationships to disclose. And why are we discussing ROP? Because it's a leading cause of visual impairment and blindness among prematures worldwide. As she stated, 36 to 48% of the incidences right now stated in India. The most important risk factors are early gestational age and low birth weight, and currently countries like India and other developing nations are facing a third epidemic of ROP. The aim of my study was to estimate the prevalence, identify the risk factors, and assess the outcomes of the management that we had performed in our center. It was a retrospective cohort analysis with a duration of 3 years, the study location being NICU of a tertiary healthcare center, and the screening was performed as per the Rashtriya Bal Swasthya Karyakram guidelines. In fact, there's a new Muskan scheme also running by the government. Cases were classified according to the international classification of ROP3 classification, and the fundus photographs were acquired on RedCam Trinetra Neophorus. We had a total of 371 infants screened during that time, out of which 103 had ROP. On the left hand side, you can see concentric rings around the fundus diagram. That is how zones of the ROP are divided, and on the right hand side, there's a pie chart which shows the distribution of the stages in my screened group. Most of the patients had stage 2, that is a demarcation ridge, and followed by stage 1, that is line. I have skipped up most of my results because of paucity of time. Anyhow, the most important ones were that the risk factors which we assessed were classified into 2, maternal and neonatal. Upon neonatal risk factor assessment, oxygen supplementation was found out to be the most statistically significant, and 88% of the ROP, 88% of the infants who had ROP had supplementation in any form, either prongs or ventilatory support. The distribution of birth weight, as you see on the bar graph, most of the major chunk of the patients had less than 1500 grams. 65% of individuals belong to the less than 1500 gram group. Now, our study found a positive correlation with low APGAR score. APGAR is an acronym that stands for appearance, pulse, grimace that is seen on the face of the child, appearance, and respiration, which is usually performed at the NICU setting by either paramedical staff or neonatologists. So the APGAR score, which was calculated at 1 minute, had, I'm so sorry, there's some, I guess, sir, please do not move. Yeah, thank you so much. Yeah, the mean APGAR score that we found at 1 minute was 3.96 plus minus 0.52. The standard deviation was such. And a normal APGAR score, as we all remember from our PEDS class, was 7 to 10. But the ROP kids had a very low APGAR score at 1 minute. The intervention were taken as per the ET-ROP and BEAT study. We performed laser barrage in 17 eyes and instilled intravitreal bevacizumab in 2 patients, 2 eyes. 1 patient denied giving any consent. There was an iatrogenic posterior capsule touch in one of the patients, so we had to perform lensectomy with posterior capsulotomy and antivitrectomy for the complicated cataract that we gifted, and it was performed by a visiting surgeon. Stage 4 and 5 ROP were referred to a higher center, and rest of the patients were followed up accordingly with the IC-ROP classification. I need to point out that in the era of anti-VEGF injections, it is not entirely necessary to just jump upon and go ahead with the anti-VEGF injections. There are few cases where I have seen zone 2 stage 1 ROP with popcorn vessels and stage 2 ROP with popcorn vessels. They had spontaneous regression by 38-39 weeks because most of the ROP doctors dealing with ROP jump upon with anti-VEGF injections. There's one case with stage 3 plus disease and it had a notch as well over here. So it was stage 3 entering zone 2 anterior. We had performed laser barrage again. We could eliminate the use of anti-VEGF. We deal with a very low economical status population. So we need to carry on our decisions wisely. In this case, only laser barrage was done again at 35 weeks, and post laser you can see the fundus photographs here. It is doing, the patient is doing great. So prematurity in itself is the biggest risk factor we know. And there are many studies carrying on in, across the world saying that there are many risk factors, but hyperoxia is one thing that our country does not really point it out because the fluctuations of oxygen is the main culprit here. We right away flush the patient with oxygen and remove the oxygen support as well, and this is what happens in tertiary healthcare in UP, I would say. And that hyperoxia stage during the early postnatal period can start a cascade of vascular and tissue events. So we need to be careful when we are doing this. Apgar score is one criteria that can be used by paramedics and doctors in peds and ophthalmology department, which can be used as a marker for prognosticating ROP. We do not need anti-VEGF in all cases. Zone 2 and 3 with stages less than 3 do not require intervention as seen in this study. And laser barrage and anti-VEGF injection, both modalities were studied in this group. But I do not have any long-term sequelae right now in this study because I'm working on a paper. We have myopia and few patients with macular drag also seen. Yet I would probably present it another time. Thank you so much.
So I am a little bit inquisitive. As per preterm babies are concerned, normally what type of Apgar score do they have?
Ma'am, both 1 minute and 5 minutes.
Yeah, so in preterm babies, what is the mean Apgar score that these babies have with or without ROP? What I'm trying to ask is this.
The literature says the patients would come with 5 or 6.
I am not interested about the literature. You have done the study, so you must have seen other preterm baby Apgar scores. So what was their score? What was their mean Apgar score?
Same range, 5 to 6, ma'am.
So, but the ROP had.
Yes, ma'am. We did not run any statistical data on it, and we have a proper register. It's not uploaded on any software. We just have a manual data register where we put up all the.
Right. You have come to this conclusion that Apgar score is an important risk factor.
Important parameter that can help us that the patient might have a severe ROP in further cases.
That's a risk factor, isn't it?
Yes.
So how did you come to that conclusion?
We had a ROC curve, receiver operating curve, ma'am, against the same data. We plotted it against it, and then it was found that it basically is 1 minus sensitivity versus the specificity. The graph is run on it, and there's a perpendicular line which is drawn. The ROC curve is given by MedCalc software, ma'am, or SPSS
ROC
software.
Curve, yes, I know what
so the sensitivity was 78%. So it pointed out that it is a very nice criterion that we can use. So we started the same thing. The neonatologist and the nurses now inform us beforehand that the Apgar score is so and so, and that is how we go ahead, ma'am.
Okay, but I think it would have been interesting had you noted down the Apgar
That's
score
one lacuna,
of the
other
preterm
babies.
And compared the two, then probably it would have.
So that is to
it
say,
would have a greater weightage of this
right. So
analysis.
that is to say, if you are talking about a risk factor, you have to have a measure of risk.
Okay. I mean,
and correlation is not a measure of risk, right?
Yeah, you have to find out the proportion between the low Apgar score and incidence of prematurity or something like that.
Sir, I'm really sorry.
I mean, if the Apgar score is low, incidence of prematurity is more.
Yes. The severity is more.
That
yes, sir.
That you want to establish.
Yes, sir.
So you have not done a positive relationship.
It's more like a tunnel vision only in ROP kids. I should have included.
Picked up, exactly.
Yes.
You've just picked up the ROP
One
kids
section.
and disregarded the kids who did not have ROP.
But
should have studied them also. Then a comparative one would have been.
It's a retrospective study. I do have the data. Yeah, thank you so much.
So Dr. Ritu has a lot of work to do now.
Indeed, sir.
Let's move on to let us now move on to Dr. P. Monica. Okay, so the presentation is on advanced glaucoma in unilateral congenital ectropion. Congenital ectropion UVA child with underlying neurofibromatosis 1. Okay. Dr. Naila, you'll be back at the end of the sequence of presenters, so please be ready.
Good evening everyone. Today I am here to discuss a rare case of advanced glaucoma with unilateral congenital ectropy and UVA in a child with neurofibromatosis 1. Sorry, my slides are not moving. Can you reset it? The child presented to us with a complaint of drooping in the right eye upper lid since 10 months. On examination, he had a best corrected visual acuity of 460 in the right eye with an IOP of 28 mm Hg in the right eye. In the left eye, he had a normal vision and normal IOP. On anterior segment examination, the child had plexiform neurofibroma in right eye eyelids and there was inferior third corneal haze in the right eye cornea with peripheral anterior synechiae in the anterior chamber and leash nodules in the right eye and ectropy on UVA with restricted extraocular movements. In left eye, there were leash nodules in the iris and rest of the findings were normal. Here is a pictographic representation of the findings. This is the plexiform neurofibroma in the right eye and there were congenital ectropy on UVA and peripheral anterior synechiae in the right eye, and here I am showing you the leash nodules in the left eye. On gonioscopic examination, the child had anterior insertion of iris with angle dysgenesis in the right eye with broad-based peripheral anterior synechiae, and the left eye angle structures were open and there were irregular patches of pigmentation around the angles. Posterior segment evaluation showed a CDR ratio of 0.9 in the right eye with diffuse RNFL thinning. Left eye cup disc ratio was normal. On systemic evaluation, the child had cafe au lait spots. On imaging, MRI showed optic nerve plexiform neurofibroma on the right side and temporal lobe herniation and sphenoid dysplasia. So after seeing all the findings, what could be the diagnosis? And here is the correlation of findings. Advanced glaucoma, cafe au lait spots, optic nerve plexiform neurofibroma and angle dysgenesis, pointing out our diagnosis towards neurofibromatosis 1. How did we manage this child? Initially, the child was given medical management with dorzolamide 2% and timolol 0.5% twice daily in right eye. Subsequently, the child underwent right eye orbital debulking and 6 months later, a non-walled glaucoma drainage device with a tube insertion in anterior chamber was done. This child was followed up after 1 year and the right eye best corrected visual acuity was 460 and IOP was 16 mm of Hg, which was within normal limits. So coming to the discussion, so glaucoma is a rare complication in neurofibromatosis 1. It is 23 to 50% in orbitofacial involvement and ipsilateral lid plexiform neurofibroma. And the various pathogenesis include developmental angle anomalies, neurofibromatous infiltration of anterior chamber angles, ciliary body, choroid and anterior synechiae. And the various management options available are glaucoma filtration surgery and drainage device placement. So what is the take-home message from this case? In our case, a comprehensive glaucoma evaluation, which was supplemented with imaging and surgery, played a crucial role. So, in cases of childhood glaucoma, a stepwise thorough glaucoma evaluation and timely wise management can prevent blindness. These are my references. Thank you.
So I have a comment to make. Whenever you're presenting, say, a case or a case series, you have to compare and contrast it with other cases or other related documents which have been published in peer-reviewed literature.
Okay.
So, is there something that is already published and you can associate your findings like X,
Sir,
Y,
I
Z?
saw one publication which was done, sir. It
Yeah,
is in
XYZ found a case of this with these findings.
it
and
has a
observed
similar, like that article also has described a similar presentation, sir, but the age group was little different.
Yes, so this is the discussion that we were expecting in the slide. Okay.
Okay,
So we are not here for a class on the neurofibromatosis but we are here for research. We are here for understanding the clinical implications of your findings.
Okay.
So,
Yeah. So how common is peripheral anterior synechiae in neurofibromatosis?
Ma'am, it is mentioned in the, according to the articles, a review of literature, it is mentioned if there is orbitofacial involvement, then the incidence is given like 23 to 50%, ma'am.
And what is the cause of this synechiae?
It can be due to the neurofibromatous infiltration in the angle structures.
Because normally what is the type of glaucoma you see in neurofibromatosis?
Ma'am, it's a congenital glaucoma which is secondary to this neurofibromatous infiltration.
Okay. It's an open angle glaucoma, isn't it? You get an open angle glaucoma. Okay, thank you. Anything else?
that is to say that the dysgenesis is basically a histological term, and dysmorphism is what you see on the gonioscopy.
Okay, sir.
Okay, right. So thank you very much, Dr. Monica and Dr. Shivam Gupta. Okay, okay, let's go with Dr. Shivam Gupta, and then we can come back to Dr. Naila Aftab. Clinical and surgical outcomes of Stooge-Weber syndrome. I'm going to have dreams. I'm going to have dreams of Stooge-Weber syndrome tonight.
So, very good evening to all, and so we are going to discuss today about clinical course and management of patients with Stooge-Weber syndrome. So, as we know, glaucoma presents around 30 to 70% patients with Stooge-Weber syndrome, and approximately 60% of patients present with glaucoma at birth, and 40% manifest glaucoma later in life. Management glaucoma in patients with Stooge-Weber syndrome is a complex because of its early onset and resistance to conventional therapy. So, our aim was to evaluate the treatment of clinical course of Stooge-Weber patients who visited glaucoma clinic. So, what we did with a 3-year study in the glaucoma department, and we discussed about what are the outcomes of it. So, basically we recorded the age, gender, side and the phase of involvement, whether it was unilateral or bilateral, how was the brain involvement or any CNS involvement, anterior segment details, posterior segment examination, and then we recorded what are the total number of patients, how many of them had glaucoma, how many had required surgical management, and whoever had the surgical management, we went out for the 6-month follow-up to look at the IOP control. So, our results showed there were 26 patients or 26I, and females were more than male with 65% predominance. Age of presentation, we had a varied age of presentation from 32 days to 68 years. Associate features were seen in 26.92% with radiographically significant findings. Other syndromic association was one patient had Klinefelter, one had phacomatous pigmenta vascularis, one had neurofibromatosis. Face involvement 65.38% had left eye and 30.76% had the right eye, and 3 patients had oculomelus nevi. Then results show that prominent eye episcleral vessels were present in all the patients. Blood in Schelm's canal was present in 19.23%. Posterior segment involvement in form of dilated tortuous vessels were present in 10 patients, and choroidal hemangioma were present in 11 patients. So, coming on to glaucoma part, around 88.46%, that is 23 eyes had glaucoma. Coming on to management, 4.7% were medically managed with mean 2 AGMs, and 65.2% required surgical management. Coming on to surgical management, we did a combined trap for 14 patients. Primary AGV was done in single patient, and of course there was a repeat trap out of these patients, and there was a repeat GDD, 1 AGV and 1 RD implantation, and there was significant reduction of mean IOP and mean number of AGM. Coming to this, total reduction of IOP being 69.84% at the end of 6 months. So, as we discussed with the other previous done studies, there was our data was comparable to them with a little more sample size, and they had shown a 41.7% success. And so, to conclusion, glaucoma is a common occurrence in Stooge-Weber patients, with the majority patient will need surgical intervention. Trabeculectomy combined with trabeculotomy should be the first surgical choice, considering good IOP control. Thank you.
Okay. Very nice. I like the study, but I would like to know what are the complications that you have encountered during the surgical intervention of these patients, because they are known to, they are more prone to complications as compared to other.
Yes, ma'am. Definitely, one patient we were aborted expulsive. We had a aborted expulsive.
You had one expulsive?
No, ma'am. We were feeling that we might go aborted expulsive, so we stopped immediately. We called the patient after 6 months, and we did we went with a valve implantation for that patient.
Okay. Others, any other thing?
Bleeding excess was there, ma'am, but it was well controlled, not any significant, ma'am.
Okay. So, anything else you'd like to ask?
Sir, would like to add anything?
It's all right. You didn't go for mitomycin C.
Mitomycin, yes, sir. We definitely give mitomycin C for
That
our.
you have not mentioned.
Okay, yes, yes. I didn't mention the surgical steps. I missed it. Sir.
Okay.
So you did get a lot of cases of this comparatively rare disease.
Sir?
Yeah.
That's true.
It's a rare
3
disease.
years, I guess. It was
3
a
years.
prospective
A long-
3.
Yes, sir. 3 years.
Long study with a
Yes, sir.
with a follow-up for outcomes. Okay, thank you, Dr. Shiva.
Thank you, sir.
Now,
Thank you.
now coming back to Dr. Naila Aftab. Presentation: Systemic Association of Congenital Ectropy and UVA.
So should I start? Good evening all. The presentation topic for today is Systemic Association of Congenital Ectropy and UVA. So it could be congenital and acquired both. So acquired is the condition where there is other secondary involvement where the patient develops NPI which leads to fibrosis, and then the patient develops ectropy and UVA where there is ectropy of the posterior pigmented iris epithelium. So CEO patients have glassy smooth iris with anterior iris tooth insertion and TM dyskinesis. Mostly they have open angle glaucoma, but later it converts into angle closure also. Associated syndromes already been in the literature is neurofibromatosis, Prader-Willi facial hemihypertrophy, and Riga anomaly. This is a neurocristopathy because it is attributed to the arrested development of NCC. And another document why it is neurocristopathy is that Muller muscle is also involved. Such patients present with mild ptosis also. So we have two cases. Case first was of a 15-year-old male who had diminution of vision and headache from the past 1 year. He was already diagnosed with glaucoma in the left eye and on topical AGM. At presentation, visual acuity was 6.9 and IOP was 28. And on Hertels, the values were 21 and 23 at base 110. We can see a left-sided facial scar which showed cleft lip surgery in the past, left-sided ptosis with mild proptosis. The anterior segment photos showed a crippless iris with ectropy UVA 360 degrees. Fundus photo showed a vertical cubitus ratio of 0.8 with disc pallor and inferior NRR thinning. So the patient had fluctuating IOP with even on AGM. So he was planned for trabeculectomy and is doing well and has achieved target IOP in the 6th month of follow-up. Second case is that of a right eye female with of 27-year-old who had a right eye diminution of vision. Vision was PL positive and patient had RDS with her right-sided facial hemihypertrophy, mild ptosis and proptosis also. GAT was 38. Anterior segment photo showed a 360 degree of ectropy UVA pupillary fill of 3 to 4 mm, which was abruptly terminating at temporal pupillary margin. And the gonioscopy showed a high iris insertion. The cubitus ratio in the right eye was 0.9 with NRR thinning, and with the left eye fundus was normal. Patient was advised trap, but since she came for cosmesis for the squint surgery, she denied for trabeculectomy surgery. So CU is a rare ocular disorder with trabecular dysgenesis along with anterior placement of posterior pigmented iris epithelium. These conditions could be confused with other trabecular dysgenesis like Axenfeld Rieger. Till date, only 100 cases have been reported in the literature, and these are all associated with Prader-Willi or neurofibromatosis, but none have showed other systemic association like in our case series. So such patients have high risk for glaucoma and in early childhood, and they present even around teenage group. So these are non-progressive to begin with, but later on as the glaucoma becomes angle closure, they become progressive. So there was stark difference in the age of presentation, that is, it was around a decade. And so this shows how early presentation saves the vision, and TRAB is also necessary. Though a rare syndrome, its association with systemic disease and progressive glaucoma in children
can culminate in potential blindness, and angle surgery, although it's a mainstay for childhood glaucoma, does not yield good control in CEU. And irreversible nature of the disease makes it to be more important to be evaluated periodically. Thank you.
Can you please repeat the gonioscopic findings of the two patients?
In the first patient, the gonioscopy was in post-trabeculectomy surgery, where we can see the patent PI, and there was anterior root insertion of the iris. And the second angle, in the second patient also we had the same findings. And one thing which I forgot is that the second patient had adenocarcinoma of the colon, for which she was operated 5 to 6 years back. That was the syndromic finding in the second patient.
Yeah, I was wondering what was the systemic association in this case.
Adenocarcinoma.
So adenocarcinoma of the colon. Is there a genetic or a polymorphism which has been implicated in this? Does the literature say something?
Some genetic polymorphism has been suspected, but not for carcinoma colon. Like something like this has not been reported.
It has not been reported previously. And the systemic association in the first case?
This has also not been reported. Only associations have been with neurofibromatosis and Prader-Willi and facial hemihypertrophy, which was present in both the patients.
That was there?
That was there in both the patients.
In both the patients, okay.
The first case is, what?
Hemihypertrophy.
Sir, you would like to ask?
No.
Okay, so brings us to the end of this session. Presenters who are here, please stay back for a group photograph.
Need to add them?
Yes, we need to add.
Okay.
Fortunately, the last session of the day allows us a lot of time.
For the edition.
So in the time the scores are being evaluated, my advice to all the presenters and the prospective presenters present in the hall is that you can go back and look up the proceedings of the previous conferences, and you have the list of best papers, the best Hyde Park presentations, the best poster podium presentations, the best posters, the best videos. You can look up those presentations on the YouTube and the AIOS proceedings, and you can get back and improve your presentations. And take this feedback constructively. That is because the experience that is being shared is for the benefit of everybody. I can learn from you, you can learn from me, and AIOS is all about learning. Okay.
Someone is left spectators for the previous session. So just inquiry if the previous judges inquiry. They have left the specs, please read the specs to me.
I can hand it over probably.
But you don't know who is.
Does it belong to Dr. Srini? He doesn't wear
Yeah, let's take a photograph. Yeah.
Presenters. Huh? Presenters, please come.
So you are Dr. Manas.
My name is Pratik. I was roped in the last minute.
Acha.